Hi, Sonia. You don't want me to put the presentation yet, huh?
Hi, Dr. Albert. Hi, Dr.
Uh,
Alvarez. You can go ahead and practice it just to make sure it's okay. Let me make sure you can share your screen.
I'll do a boo-boo. Uh, Let me see. So are you seeing the slides?
I see all of the slides here.
Yeah,
Yes, ma'am.
I want them to be on my front. Well, let me see if let's see. Okay, let me just share the my screen. Do you, okay, now you're seeing my Zoom screen. That's what I would like to do, because here then I will put it, let's see, I will do like this. You can see them now, right?
Right, I see all of your slides right now.
Okay, perfect. Hopefully that won't be a problem, but
Okay. All right then. Thank you. How's your day going?
one meeting after the other. I was in
Yeah,
another meeting, just I said, let me log off. Yeah.
yeah. So well, you had a really short meeting with your project officer from Versa. That was
Yeah, I told her
impressive.
I don't have anything else to say, but there was always something. We talk about a few things, like the DEI business.
Oh, yeah.
That's a little bit conflicting.
Yeah, it's interesting. It's really interesting and really kind of backing cities and organizations into a corner with all of that and you
Right,
know,
right.
forcing their way through.
I don't
So
think it's going to affect us, personally. I don't think it's going to affect us, but anyway, I hope not.
I wondered, that's good to hear. I was wondering about that because of some of the metrics that we have to report. Some of the metrics are related to like race and ethnicity. So I was wondering how that would, like, will we not have to report that anymore? Or is it going to be a
That would
matter
that should be reported. But
of,
there is,
okay.
like for HRSA, there is a component of the equity. Because one of the questions, right?
Mm-hmm. Mm-hmm.
How that is going to be impacted. I guess we have plenty of time, because I won't be until next year, right? Or December.
Well,
We will be
yeah,
until
well,
December.
they usually send it out around like August, September, right? So about 3 months beforehand to let you know. So it'll be coming up soon, sooner than we
Mhm.
realize. So we'll see what they have to say.
Mhm.
Okay. And you just as a reminder, I mean, you're a pro here, but you know that the case will go first.
Yeah,
So we'll do our introductions and then you'll present first.
yeah, yeah.
Okay.
Who's presenting the education today?
Dr. Pho, he's doing on
Okay.
um, oh gosh, sleep, sleep apnea, I believe.
Oh, okay.
Obstructive sleep apnea in
I
children.
presented that before. I don't know whether you remember, but it was like a year ago.
Ah, nice. That's good though. We have people who are always coming in,
Mhm.
so people are always changing out, so it's good.
Yeah.
All right, I'm trying to find something. So I'm going to mute myself so I'm not like clicking in your ear.
Mhm.
Hi, Dr. Fudd, did you want to give your screen share a shot? Just make sure everything is going okay there. Oh, actually, I've got your slides. Never mind. I'm sorry. My apologies. Okay.
Hello, hello.
Hi.
Hello.
It's giving everybody another couple minutes to jump on.
Hi, Sonia. I may need you to move my slides. I am somewhere where I cannot share my screen.
No problem. I have your slides pulled up.
Thank you.
Mhm.
Give it one more minute as everybody's joining. Travesty, I'm out of Red Bull. All right, I am sure we're gonna have some late joiners. I just saw 3 more people pop in, but let's go ahead and get started with our introductions. Sonia, if you want to throw up our slides.
All right. Well, good afternoon, everyone. We have our accreditation and EOE statements. We do not have any disclosures from Dr. Fudd. And then you can scan the QR code here on the screen, or you can click the link that is in the chat box for your CME credit. And then just a couple of announcements, the scholarship opportunities. I believe I emailed these out to everyone, but I'll also send them in the follow-up messages. But these are scholarship opportunities for high schoolers and college students. So college, university, vocational school training programs. So those are coming up due in May. And then also the conference that is taking place virtually May 7th and 8th, and we'll have the link there and the brochure also attached to the follow-up email. Thank you.
Thank you. All right. I think Dr. Alvarez is starting us off today with a case from the University of Miami. Are you here, Ophelia?
Yes, I'm here.
All right. I'm handing it over to you.
Okay. Can you see the slides?
We don't see them in presentation mode. We see them in
Oh,
slides.
no, I'm going to do that. Yes. So, you can see one slide now, right?
We are perfect.
Okay, very good. Well, thank you for the opportunity. And this is a patient I have been following now for close to 2 years. And the mother actually asked me for a second opinion. So I said, well, this is a perfect opportunity for me to present this case. So she is a 7-year-old right now who has SS, and she was diagnosed with sickle cell anemia in Jamaica at the age of 2. Never had a TCD, and the preceding history was history of acute chest, splenic sequestration, and pain crisis. And the first time we saw her at Jackson was July 4th of 2023. And at that time, the fetal hemoglobin was very low at 4.5. And she presented to me for the first time in August of 2023 when she was 6-year-old, and she presented with a stroke. This is the reading of the MRI showing a recent infarct in the right basal ganglia and external capsule. And there was findings were suggestive of acute to subacute timeline. The brain MRI showed, and the MRA showed multifocal stenosis, origin of the right M1, division of the MCA, multifocal severe stenosis of the left A1, ACA, and moderate narrowing of the right A1. And this is the original MRI and MRA pictures showing this area where she had the infarct. And here's the MRA showing narrowing of the right MCA and also bilateral ACA segments. She obviously had an exchange transfusion targeting for less than 30%. And then I put her on chronic transfusion with the same target. The neurosurgeon was following her very closely, and she had a CTA done 2 months after the stroke. So that would have been around October of 2023. And she had progressive narrowing and significant narrowing of both the right MCA and the right ACA, actually more than the left ACA. So everything was on the right side. She also developed seizures and has been treated with trileptal. Her hemiparesis resolved. Around November of 2023, she had surgery. She had a right temporal craniotomy for a pile synangiosis, an indirect revascularization of the MCA territory, and a separate incision to revascularize the ACA territory on the right side. And after the surgery, at that time, we placed a PICC line, and she actually developed a DVT of the left subclavian axillary veins. So since that time, the mother was very nervous about putting a port on her. She had an enoxaparin for at least 6 weeks, but the bottom line is that the child has very poor venous access, and the mother had refused to place a port for transfusion repetitively. So what I do is I admit her every 4 weeks for transfusion. And because actually the problem is more with the nurses in clinic, but in the hospital, we have a different team and they are able to put the IV. And most recently, I'm transfusing her every 3 weeks to keep that S down. Something peculiar about this case is that since the very beginning of transfusion, she actually developed a rash, pruritic rash in the extremities and the trunk. Shortly after each transfusion. So there were at least 3 occasions that she developed this rash. And originally we thought, well, could it be graft-versus-host disease? So we started reading the units. But after consulting with our immunologist, we decided to wash the units. And apparently it's something in the anticoagulant of the units. After the units have been washed, then there have been no reappearance of the rash. They have been, back and forth with this mother in terms of whether she wants us to continue with transfusion or not. I have to do a lot of convincing with her. This is for you to see tracking of the S levels, starting with the exchange. So obviously after the exchange, we had 30%. At the beginning, she developed some auto and allo antibodies. This is the time when we started washing the units in January of 2024. I basically kept on simple because of the difficult access. I wanted to do partial phlebotomy and simple transfusion, but again, difficult because of her IV access. You see here that this is suboptimal because most of the time she has been in the 50% pre-transfusion. And I use the formula that I learned from Russell Ware, targeting the 11.5. So we calculate the volume based on the observed hemoglobin and targeting 11.5. So the mother kept insisting about hydroxyurea. And I said, well, the minimum I can give you transfusion is a year. I mean, obviously not ideal, because switch demonstrated that patients with moya, patients with severe stenosis, even though I have done surgery with this kid, the best outcome is with continuing transfusion. But I started her on hydroxyurea with the idea of doing this transfer to transfusion to hydroxyurea by itself. And then when I was going to stop the transfusion, this is what we got. I did an MRI. I mean, we have done a few MRIs all, along the line, but she developed acute lacunar infarcts in a territory which actually was posterior to the MCL. And the neurosurgeon actually wanted to do more surgeries, but the mother was adamant she didn't want that. Now, the MRA shows good vascularization, so she continued to have good perfusion, but this was not as bad as originally, but she did have that lacunar infarct. So I kept her on transfusion, and this is what we're doing now. So I'm checking pre and post, and at this time, I wanted to, after I saw that, with the lacunar, we did another exchange. We transfused first and then we did exchange, and this is what we got. But you see, 4 weeks later, she was back up with a very high S. I don't know, part of it is, we're using the washed blood. So maybe the survival of the blood is not too good. That's what we have been telling the family. And then here I did it every 2 weeks. And then right now we are every 3 weeks. And this was the best I could achieve just immediately after. So when she comes in, we do the pre and post. And this last one, she actually did not get all the blood that we needed because I wanted 11.5. Actually, the post-transfusion hemoglobin was 10.1. So I'm going to see her back this week. On Thursday to monitor how she's doing. So I have continued her on the transfusion every 3 weeks. She's on aspirin and she's on hydroxyurea at the present dosing. The mother had been opposed to iron chelation, and this is the most recent, and she's opposed because she's scared of side effects. I mean, I have mentioned it to her multiple times. But August of 2025 will be 1 year after the lacunar infarcts. In May, we are going to do a perfusion scan just to monitor her. And of course, if we stop the transfusion at some point in time, I have to do much more frequent monitoring for her. This is the most recent CDC. showing an ANC of the 4,000 range, an MCD elevated, and the plates are normal. So the questions is, any advice about transfusion for a better red cell survival? I don't know whether the hydroxyurea may be contributing to the increase, I don't know, A, or increasing the A, I will say. And any discussion about this is continuation of transfusion with increasing hydroxyurea to MTB. So these are my questions.
I have a question for you. With the rash that she was having, did you try just regular old Benadryl or Zyrtec before her transfusions?
Yes, she's pre-medicated every time with Tylenol and Benadryl. I'm not using steroids, but we did use Benadryl. I remember at the very beginning we were doing that even after when she developed the rash. We also asked the blood bank to see her. We asked dermatology to see her. I mean, she was evaluated, and it was not until the allergy immunologist say, hey, I have seen that before, and it's from anticoagulant, and then we start washing the units, and then she did not get it again. That was one of the arguments against, continuation of transfusion for the mother.
I mean, I agree with you. I think if you stop transfusion, she's going to have a stroke.
Yeah.
I wouldn't, or I certainly wouldn't do it willingly.
The problem is, Julie, that I basically have to admit her every time, and it's difficult. And of course, she doesn't want the port, because if we place the port, then we can do it in clinic and we can do whatever, the phlebotomy and things like that. So that is what I'm facing. It's challenging because of the oppositions. But I can say, we have 20 people here saying continuation of transfusion is the way to go.
This is Beng here. I think some difficult things you're going to run into. One, they don't want chelation. With you not transfusing every 2 weeks, you're going to run into severe iron overload pretty soon. And then looking at the even the post S is not dropping that much, with the exception of one value. All your pre-S's were above 50%. So the question is, you are getting some protection. How far is that protection? And can we assume that with hydroxyurea also being on top, at least the S that's being produced is being produced under the influence of hydroxyurea? So that together with the even though suboptimal transfusion is giving you enough protection that one can feel comfortable continuing.
So you're saying to continue both, just to have the additive protection. So here you see, because I was decreasing, or I was less on top of things around August, right? That's when she developed the lactinular infarct. You can see that it was 74%. So she knows basically when it approaches that the kid is at high risk.
Yeah, I'm just speculating, right? Because I think the transfusions are not providing the levels that we normally would shoot for. So since this patient is suddenly making a significant amount of their own hemoglobin, perhaps making it under the influence of hydroxyurea, may give additional protection.
Right.
Hey, Ophelia, this is Hamayun, from Mobile. There's a similar question on the ASPO forum that was circulated. I think kind of most people, said last week that they wouldn't, stop the transfusion because there are no data. But these are life challenges, and you kind of go through. So as long as the mother is aware about the risk of stroke, and we have maximized the hydroxyurea kind of dose and the highest MCV that we can achieve, maybe we can slow down the progression if we stop the transfusion. I also believe that, doing some transfusion and not kind of meeting the requirement of less than 30, if you are kind of 45 or 50, it's still better than 95. It is. But
yeah, for sure.
You have the iron overload, that is going to be a big deal long term. That's going to be a big deal long term. So we need, to just, kind of look into that. And, as long as, the family is compliant with hydroxyurea and is compliant with your follow-ups and has these concerns and absolutely don't want the transfusion, then, they just need to, to be informed about this, that there is a high risk of whatever we do. I don't know what else, can one do.
Yeah, well, that's exactly what I have been doing every time they come in. I mean, she has been
Right.
doing better recently.
Right.
But every time she comes in, we have to go over the whole thing again. So she needs to know what the risks are. And again, the best treatment is transfusion. If she doesn't accept that, then obviously hydroxyurea is the second best, but obviously the risks are higher. And we have the issue, if she continues transfusion, she needs to be compliant with the iron chelation, which is another issue. Yeah.
Correct. Hey, do you want to tell us, the reticulocyte count, is it high? It's still high, right?
The reticulocyte count, it is high. I mean, I didn't put it here, but yes,
But it's
it
high.
is, yeah, let's say 6% to 10%, something like
Right.
that.
So there's still, some reticulocytosis that, you would incorporate the hydroxyurea and would have the benefit that we see, from the MCV. Another thing would be, as you said, that I, would follow it up closely. If there is some progression on stenosis on a very close MRI, maybe you can kind of start the discussion again about, see, I'm talking to you that there are further progression and, like a stroke is imminent. I think that'd be one way to, to deal with that while, kind of sitting on a, taking time bomb.
Right. I mean, I think she needs to have scans every 3 months, basically, at least for the first year, while if we stop the transfusion.
Have you talked about transplant?
Yes, I have. And she says no. She
Well,
says no. I mean,
okay.
the transplant, because that would be, I think, in my opinion, that would be a very important option for her. But she's opposed to it.
Has
Yeah,
she at least accepted to HLA typing? Are there even matches before you go to what type of transplant it would be?
This is an only child with the mother. The father is in Jamaica, and she expresses that the father is against all of these things, although they are not together. Yeah, and of course, if she was in Jamaica and she would have had this stroke, what we would have done is exchange probably, and then no transfusion later on, because they have had issues with transfusion, with blood supply in Jamaica, right? So that's what they do, that there is a standard of care over there. And she knows that. So, I mean, the only thing I can do is keep educating the mother and try to work with her, but that's all what I can do.
I would just make a comment. I know it does not always help, but I have run into a similar situation where we know that transfusion is what is needed, and you need chelation. Sometimes I do involve DSS, not that they're always helpful, but it sometimes drives home the point to the mother that this is serious and
Yeah.
that there's some leverage that you have. It can backfire and totally mess up your relationship with them.
Yeah,
And
I don't think that the DCF is I wouldn't call DCF from this mother. I mean, the mother have been super compliant. I mean, in terms of, follow up, she has been. So she's not a negligent mother. She just have her opinion, and just difficult to reason sometimes.
so I would really insist on iron chelation. I just saw 30-something-year-old die of iron overload, heart failure. It's not pretty.
Yeah. And we actually had another patient, Julie, that she's not a sickle cell patient, but she's a patient with aplastic anemia. And she developed very significant cardiomyopathy. She went into heart failure recently.
Yeah, we unfortunately had one die of liver failure recently and one who's in the ICU with heart failure now.
Yeah. And I have another case that I may have to discuss in an ethics committee, because I have been dealing with family for 18 years, and it's very challenging. because of the lack of compliance and things like that. So I may have,
Definitely a hard case.
all right.
Well, thank you for presenting and thank you everyone for commenting, and you'll have to let us know. We'll have to have a follow-up and find out in maybe the next 6 months or so what you're doing and how she's doing.
Okay, I will.
I am excited to have Dr. Fu here today. He is going to talk about sleep apnea and sickle cell disease. We were actually talking about this morning as well. Dr. Fu is tremendously accomplished in so many different areas and is division chief of Peds HemOnc and director of research at Eastern Carolina Department of Pediatrics. So Dr. Fu, I could read all your accolades, but I think I'm just going to turn it over to you.
Thank you, Julie. So first of all, I would just say I'm not an expert on sleep apnea. I actually brought this up because I thought we would discuss and get some feedback from you. So yeah, we could move to the next slide. Next one, please. So though this is not a case presentation, what brought me to start thinking about this was actually a case. So I did some literature. So I will just talk briefly about this young man. So 14-year-old with daytime sleepiness, admitted for VOC, noticed to have DSATs at night, does have a history of acute chest syndrome, has previously had abnormal sickle stroke screen, was on transfusions, transitioned over to hydroxyurea. Next slide. So we got a sleep study, was found to have severe sleep apnea, started on CPAP, good improvement, sleepiness, daytime sleepiness got better. They ran into significant social issues, including homelessness, lost the CPAP machine along the way, having a lot of trouble getting another one. Even when they're in the hospital, we cannot get that. Finally, now we're able to schedule tonsillectomy, which we had scheduled in the past and they would just not show up. But now we have figured out they have an appointment next week. Hopefully that will get done. Next slide. So when we're trying to figure out, okay, what do we do now that we're having issues with the CPAP machine? I said, let me go back and review some of the sleep apnea data. Then interestingly, about 12 years ago, Dr. Sharma was here, a pulmonologist, and he was really interested in sleep apnea. So we did some sleep apnea studies, both on children and adults. And some of the data I'm quoting here is actually from him. So it's basically you have episodes of complete collapse or partial collapse of the upper airway that leads to decrease in oxygen saturation or arousal from sleep. I will not go into details of those definitions now, but this results in fragmented and non-restorative sleep. In both adults and children, this will cause cardiovascular problems, cognitive functioning problems. Again, we talked about daytime sleepiness. If you're an adult, that impacts your ability to work, your ability to drive, but also depression, other mental health problems, nocturnal enuresis in children, and overall an impact in your quality of life. Next slide. So what are some of the things that will lead to pharyngeal narrowings? One, there is a fact that you have decreased respiratory drive when you are sleeping. Then the neuromuscular factors, depending on, you could have neuromuscular disease, but also depending on the shape of your face, that could affect how your upper airway functions. With age, generally, as you get older, your risk of getting obstructive sleep apnea increases. Men generally more than females. Obesity is a factor. Let's go to the next one. So classification, the classification is different between children and adults. So for 18 and up in adults and older, in general, if you have more than 5 episodes, which are basically you're having 10 seconds of sleep apnea or severe desaturations, per, that will be counted as an event. You have 5 to 14. For adults, that's mild. For children, it's just 1 to 5. So you will see the trend here. Moderate for adults is 15 to 30. For children, 6 to 10. And severe for adults is greater than 30 events. For children is greater than 10 events. Next, please. So it's a very common disorder. So when you look at some of the data that they collect, they say 5% of adults, but there are some studies which say that it's closer to 25 to 30% of adults having obstructive sleep apnea that's clinically significant. 2% of children in general, but some studies suggest that you may be dealing with up to 10% of children having obstructive sleep apnea. Again, prevalence increases with age in adults. In children, there's a little paradox there because in the age range where you have a lot of tonsillar hypertrophy, you have more sleep apnea. As they get older, that decreases, and as adults, it starts increasing again. In general, more prevalent in males than in females. Next, please. So sickle cell disease. So we mentioned in children, the data says about 2%. For sickle cell disease, that about 10 to 40%. It's a wide range, but that's the data is all over the place. We had mentioned some of the factors that can impact in children. These are just exacerbated in children with sickle cell disease, and I will mention some of those. So can you go back to the, that was a little too fast for me. So some of the things that why it's so more important in sickle cell disease, and Dr. Sharma looked at this many years ago, is there is some clear data to suggest that it increases the complications from sickle cell disease, including acute chest syndrome, pneumonia, but also cognitive functioning. The strongest risk factor generally, if somebody comes in during the routine exam, they have habitual snoring, and you notice they have low O2 sats when they are awake, that could suggest that they could have obstructive sleep apnea. Next slide, please. So apnea generally, as we mentioned, there's hypopnea, so you do have partial collapse or desaturation of your O2. Apnea is really when they have this episode of slow breathing. We discussed, I just wanted to put here, if you're looking at oxygen saturations, so anything less than 80% that you drop at night, that's going to put you in severe obstructive sleep apnea. Next, please. So this study looked at patients who were referred for obstructive sleep apnea. So this is not all children that are just a pediatrician or a hematologist suspected that they have sleep apnea, referred them for sleep studies. So you will see that almost all of them who were referred. So whatever criteria you use, whether it was DSAT or they told you they were snoring or they told you that they were having apneic episodes when they were sleeping, whether they're children with sickle cell disease or not, almost all of them ended up having obstructive sleep apnea on sleep studies. So when they went for sleep study, you saw that they had that. If you look at children with that sickle cell disease, you probably had more who ended up being more severe, but in general, all of them ended up having, about 95 of them ended up having obstructive sleep apnea. So what this is really suggesting is that if you do a good clinical evaluation and you think they have sleep apnea, they probably do have sleep apnea, even if you don't have a sleep study on them. Next, please. So then looking at obstructive sleep apnea, when you look at patients who have symptoms, you look at how predictive is it that they are going to have sleep apnea on a sleep study if you look at it. So the younger they are, the more accurate you are in predicting that my clinical symptoms suggest that they have sleep apnea. And then as they get older, your accuracy decreases. So next, please. So obstructive sleep apnea is actually better understood than in adults because in children, we have some of the things that we can explain. Children generally have larger tonsils, they have larger adenoids. Those are the things that will frequently compress your airway, and you're having recurrent infections. You can explain that away. A lot of adult obstructive sleep apnea, apart from obesity and some of the fat distribution, we don't have clear mechanisms for that. Next, please. So obstructive sleep apnea in children, in adults, has other sleep problems that they come along with. So we are talking about obstructive sleep apnea, but there are other complications of sleep disorders that adults will have. So some studies suggest that up to 70% of adults with sickle cell disease will have sleep disturbances. We said about 40 to 50% of this will be obstructive sleep apnea if you did a sleep study on them. It's less a problem in adults, as I mentioned earlier. Next slide, please. So when you look at obstructive sleep apnea in people with sickle cell disease versus those who do not have sickle cell disease, and I think these are the points that came across to me, was that generally individuals with sickle cell anemia have more severe nocturnal hypoxia. One could say, okay, they are functioning at very high levels already and we're sleeping and they cannot get enough air in there, they will have more hypoxia, but that's clearly the case. The other thing that I noticed was if you look at the thresholds for neck size that they will use to identify who meets criteria, who is at risk, who for obstructive sleep apnea. On adults, they look, you have a certain neck size, they say you have an increased risk and will refer you. It's generally about 40.3 centimeters in adults. For sickle cell patients, adult sickle cell patients, the average of those who had it was 38, so below that threshold that they have. When you look at the BMI as well, you see that the BMI for people with sickle cell disease is lower than the threshold that adults would generally look at to say, if you reach this BMI, you are at high risk of obstructive sleep apnea. So what really made me to say, let me share this because that's what I was seeing is perhaps if, especially in adults, they are looking at people, looking at their body sizes, they're looking at their, whether it's neck size or BMI, for sickle cell patients, they should be looking at a lower threshold to make that call. The other thing I asked myself, and this is speculative, is because I have not done a big study on that, is now that a lot more children are getting disease-modifying medication earlier on in life, they are going to have higher BMIs, they are going to have more obesity issues. We are likely going to have a worsening obstructive sleep apnea problem as time goes on. Which brings me to one of the concerns I had with our patient was, and where some people can also, how easy it is to get CPAP machine for children with obstructive sleep apnea, and how effective are people able to get their patients to do that. But before I continue, I think I have one more slide. Can you see if I have one more slide? I thought I had mentioned that. So the CPAP is still the one, you look at evidence-based, is still the most effective tool to use in individuals with obstructive sleep apnea. Now, if it's a wet issue, wet reduction, you could go to surgery and others. There are other things they're talking about, hypoglossal nerve stimulation, nasal dilation. All of these are things that are not clearly proven to work. So that is all I could figure out, but Julie mentioned that she was talking about sleep apnea, so I would be interested to see what other people know much about it. I think I already talked about the concluding points here, apart from the timely interventions that may be necessary. Apart from CPAP, are people using any other interventions? Because I am having a lot of trouble even getting the children to have their CPAP in the hospital, not to talk about them keeping it at home.
How often do you do TNAs for people with obstructive sleep apnea?
So I do it. So anybody who has it, you get it, then you get clearance from insurance. The ENT will do the TNA for you. We actually do a good amount of those.
And that's certainly, I have a bad running joke that if the pediatricians would just take out the gallbladders, tonsils, and adenoids around the 2 years of age, you'd make life much easier.
Some we have been able to get better just with doing allergic rhinitis, giving the anti-allergic medication. we actually get the sleep apnea to get better. But we do have some that we've done TNA and they're still having sleep apnea. This one, I'm hoping that once we get the tonsils out, because of the home situation, I don't think we can be effective CPAP on this child.
No, sorry, go ahead.
No, one thing that is very important is that we should screen the children or the adults for sleep apnea. With questions, snoring, obviously anything that is waking up with difficulty breathing, daytime sleepiness, things like that. We should be screening because it's very, very common. And the TNA is something that we do also very frequently, but it's important to do a sleep study just to document what the problem is.
Yeah, I would agree with with y'all. I mean, we don't usually screen, for that. We just kind of depend on the physical examination or complaints from the parent if the turbinates are enlarged. We talk about it, or the child snore, or if you're visibly eating it. We almost always had to do the sleep study so the insurance could pay for the TNA. So we have to document it first, and then we do that. Overall in our practice, we don't have a ton of TNA, but if we suspected, kind of somebody, we make sure that they get this study and they get the TNA done.
We see a lot, and I screen for it actually at every visit, or at my annual visits. I always ask about sleep and snoring and obstructive sleep apnea because we see it very frequently, and it absolutely, I think, contributes to pain, acute chest, and other complications. That's what we were talking about when I said we were talking about it earlier today. We have both a pediatric and adult. Both of us have grants submitted to look at this as nocturnal hypoxia, not specific to OSA, but just in general and its relationship with pain and pain outcomes.
So talking about screening, so Dr. Vary, she's now at VCU, but when she was here, she did these sleep studies where was mostly looking at sleep and pain, but was capturing sleep. So it was very high, even in adolescents. We're looking at children 11 to 17. And I speculate that a lot of it we say is because they are tired during the day because of anemia. But part could just be they have obstructive sleep apnea, so they don't have restorative sleep, and that just adds to their daytime tiredness.
Dr. Amar?
Yes, so I'm a pulmonologist, and I take care of kids with sickle cell disease who have sleep disorders. I think the best strategy is to team up with a sleep specialist or a pulmonologist because when it comes to non-invasive ventilation, like CPAP and BiPAP, you need like very good support from like respiratory therapy, social workers to make things work. And they have good relation with DMEs that can provide and follow on the supplies with the CPAP and BiPAPs. So I think that's the best thing. So what we do here at UAB is any patient who was suspected to have sleep disorder breathing, they will be referred to my clinic, and I request the sleep study, and then I act upon the sleep study. And then my team of like respiratory therapists and social workers will work on the CPAP. So what we do usually is we do desensitization to the mask of the CPAP initially. And then when the kids like are used to wear the mask when they're awake without being connected to the machine, then we connect it to the machine. We start with low pressure and then go up slowly with time. So it's kind of like process to improve the compliance with the CPAP machine. Because you are right, if you just start CPAP machine right away with the high pressure that's recommended during the sleep study, most likely most of the kids they will not tolerate the CPAP machine. So we have like very good success rate with CPAP and BiPAP for our children who have obstructive sleep apnea. But of course, we have cases that we struggle with kids wearing CPAP and BiPAP. And what we usually do is we go down on the pressure, on the duration, and start the desensitization process again. And sometimes, especially for small kids, sometimes we try to repeat the sleep study with only oxygen to see if this will kind of get them through the sleep study without having severe obstructive sleep apnea. So usually for younger kids, because you discussed the TNA, for younger kids, we usually send them for TNA. first one repeat the sleep study again with split night study. So the first half without anything, and then the second half will start the non-invasive support. But for older kids, especially like older teenagers, it's unlikely that the TNA will resolve the sleep apnea. So most of them will need non-invasive ventilation. So I think probably the easiest way is to kind of find a sleep specialist or a pulmonologist that is ready to see those patients and provide the support that they need during the treatment of obstructive sleep apnea. And we have published about 3 papers so far, 2 of them from our center, and we published a paper, multi-center study with Duke and UF about the effect of sleep on different outcomes of sickle cell disease. So as you all mentioned, it is very important aspect to look at and to treat. But this is my suggestion, is just to collaborate with a pulmonologist or a sleep specialist.
Quick question. So we do actually have our pulmonologists are actually the ones who did a sleep study and prescribe it. But we frequently run to where we have challenging families. Most services throw up their hands, and our social worker. How often can you get a CPAP machine if you lose it? Just out of curiosity, do they give a limit like 1 a year or?
Yeah, I mean, usually the DME will give us pushback if we order a new, especially if it's lost. If it's broken, they replace it usually right away. But if it's lost, then we have to convince the insurance to pay for a new machine. So this can be a struggle. But if you have any issue with the machine itself, like it's not working, usually the DME, they will replace it right away. So we didn't have any problems with the machines themselves, like getting the machines for patients with sickle cell disease who have significant obstructive sleep apnea, they have sleep study. We can get the machine right away. And then fixing the machine is usually like very fast. They will just replace the machine for them right away, the DME. But if they lost the machine, yes, we have to go through like a long process. Sometimes we have to repeat the sleep study to show that the patient still needs the machine, the CPAP machine, before we can get a new machine for them. But again, usually RTs and social workers, because we have like about 7 sleep clinics per week. We have 4 providers, 4 sleep specialists. So they work with all of them. So they have very good experience about like what to put in the letters and how to get these things done.
And since I have you here, out of curiosity, because some of our older patients, a sleep specialist said they will do a home sleep study. How useful are those home sleep studies? Are they really as?
Yeah, if you cannot get an inpatient sleep study in a timely manner for a patient who has significant disease, those can be used for screening tests, because if you do the home sleep study and it shows significant kind of sleep apnea or hypoxemia, then it will be much easier to get a sleep study in a sleep center with CPAP titration. So sometimes we do them as kind of screening while waiting for the sleep study, or to push the sleep study to be done sooner. And of course, there are patients that we cannot do sleep study in the hospital, like those who have who are on the spectrum for autism, or they have some behavioral issues. Those are the patients that we start with sleep study at home. If it does not show significant sleep apnea, then we can just manage with repeating it's called overnight pulse oximetry study. So we give them oxygen at home and repeat this the sleep study with the oxygen at home, just to get the insurance to approve their oxygen. But if they have moderate or severe obstructive sleep apnea, then we have to bring them to the hospital and do the split night with CPAP titration in the hospital. So it is useful as a kind of screening test to start with.
Thank you.
Anybody else have any questions? There's some discussion in the chat about some of the newer mouth devices that I know are being used, and I don't know much about them in terms of opportunities there. Amar, do you have any comments on those?
So they are not FDA approved for pediatric age group, but they are approved for adults. The option that we have sometimes used, especially patients who have anatomical issues with their face, in addition to the sickle cell disease, is we refer them to orthodontists. So they do some appliances to kind of improve their upper airway patency, especially if they have retrognathia or micrognathia. But for those gadgets, they are not FDA approved for children. So I have not used them personally, and I'm not sure the adult side use them.
So literature review, when I looked at the literature on them online, both mostly adults, they have very low level of evidence for their effectiveness. So they are used, but there is not strong data to say that they're beneficial.
Yeah, for our pediatric age group, if the child has a normal anatomy, then like we don't usually send them even to the OMFS or to the orthodontist. But if they have abnormal anatomy and there is evidence of glossoptosis and the micrognathia, then we usually send them to the orthodontist, and they usually respond like well to those kind of interventions.
Excellent. Very interesting. All right. Other questions from anyone? All right. Well, thank you, Dr. Fu. Thank you, Dr. Alvarez. Both interesting presentation, interesting case, and we will look forward to learning more and hearing more about the case. So thanks, everybody, and we'll see you guys in 2 weeks.
Bye-bye.
Bye, thank you.